Medical Cannabis by Genevieve Alou and Megan Liss. Objectives. Participants will report an increase in knowledge regarding the use and management of the use of medical cannabis in patient care. Participants will state at least one circumstance where medical cannabis could be implemented in their professional practice. And participants will answer 8 of the 10 questions correctly following the presentation. Herbal cannabis has been used for many years. However, medical cannabis is an up-and-coming pharmacological treatment that needs to be further explored, as research supports the use of cannabinoids for neuropathic pain, multiple sclerosis, chronic cancer, and other diseases. Being educated about medical cannabis is important in considering a patient's treatment plan. This will provide an overview of cannabis, legalized areas, administration, methods, uses, benefits, risk factors, treatment, and a summary of medical cannabis. Legalized areas. The Netherlands and Canada have government programs that have specialized companies that supply quality herbal cannabis. Moreover, 23 states in the United States, including Washington, D.C., introduced laws to permit the medical use of cannabis. Legal matters. Herbal cannabis has been used for thousands of years for medicinal purposes. Unfortunately, herbal cannabis has not met FDA standards for medical approval. However, specialized, well-characterized cannabinoids have met those standards and must be prescribed from a participating physician. Currently, there are 2 synthesized cannabinoids that the FDA has approved as medications in the United States. That includes drobenol and nabilone. These medications are the only current cannabinoids available by physician prescription. Legal matter in pediatrics. Because of state legalization of medical marijuana, it is now legal in more than half of the United States with physician certification. All states with operational medical marijuana programs allow the use by minors, but require consent from a legal guardian and certification from a physician. Specific states do require the guardian's consent to control the dosage and frequency of use. These states include Arkansas, Arizona, Hawaii, Maine, Michigan, New Hampshire, New Mexico, New York, Oregon, Rhode Island, and Washington, D.C. Moreover, some states require a second physician for the certification of the minor's use. So that's Connecticut, Colorado, Delaware, Florida, Illinois, Massachusetts, Maine, Michigan, Montana, and New Jersey. In addition, 4 states that require specific certification from a pediatrician include Massachusetts and New Hampshire. And then pediatric subspecialists, that would be Delaware, and a pediatrician and psychiatrist would be New Jersey. However, the American Academy of Pediatrics disapprove of dispensing medical cannabinoids in the pediatric population as a treatment option outside the U.S. FDA. Etiology. Cannabis is derived from the plant belonging to the genus Cannabis. There are over 480 natural components found within the Cannabis sativa plant, of which 66 have been classified as cannabinoids, chemicals that are unique to the plant. The most well-known in research of these is the delta-9 tetrahydrocannabinol. It is the substance primarily responsible for the psychoactive effects of cannabis. The effects of THC are believed to be moderated by the influence of the other components of the plant, most particularly the cannabinoids. The cannabinoids are separated into subclasses. These are as follows: CBG, CBC, CBD, THC, CBN, CBDL, CBL, CBE, CBT, and other miscellaneous types. An estimated 178 million between the ages of 15 to 64 years old have used cannabis at least once in 2012. Medical cannabis refers to the use of cannabis or cannabinoids as a medical therapy to improve symptoms and/or alleviate symptoms. Cannabis was included as a controlled drug in the United Nations Single Convention on Narcotic Drugs in 1961, and its use is illegal in most countries. Risk factors. Common adverse effects include balance problems, dizziness, confusion, diarrhea, euphoria, drowsiness, dry mouth, fatigue, hallucinations, nausea, and vomiting. In pediatrics, accidental overdose of cannabis has been associated with multiple adverse effects that include seizures, possibly from the toxicity of high-dose THC amongst toddlers. So in 62 studies, adverse events were reported that included being associated with a much greater risk of any adverse effects, serious effects, withdrawals due to adverse effects, and a number of specific adverse effects. Common adverse effects include balance problems and dizziness. No studies were found evaluating the long-term use of cannabinoids and adverse effects, and there was no evidence that the effects of cannabis differed from cannabinoids. In pediatric, accidental overuse or overdose of cannabis has been associated with multiple adverse effects. So potential harms, conclusive evidence would be chronic bronchitis or respiratory symptoms, motor vehicle crashes, low birth weight. It is associated with schizophrenia and other psychosis. There is moderate evidence that shows problem cannabis use if depressed, and then there's no increased risk for lung or head and neck cancer. And then there's limited evidence that shows an increase for CVAs, an increase for myocardial infarctions, and a COPD risk. As far as the benefits, there's conclusive evidence to show that it's helpful for chronic pain, chemo-induced nausea and vomiting, MS, and then there's moderate evidence to suggest that it's beneficial for sleep short term. And then there's limited evidence that it's beneficial for HIV or AIDS, wasting, Tourette syndrome, social anxiety, HIV neuropathic pain, and chronic neuropathic pain. Overall medical cannabis benefits. So there's a decrease in use of opiates and other narcotic medication, a decrease in polypharmacy, and a compliance in medication management. So if you'd like, you can pause this PowerPoint and play the video on research findings on medical marijuana. Pathophysiology. Cannabis is a plant that produces pharmacologically active cannabinoids, of which the constitutes cannabidiol, CBD, and THC, which are the most studied. CBD may function through a variety of mechanisms, including indirect antagonists and potentiation of cannabinoid receptors, whereas THC acts primarily as a partial agonist to cannabinoid receptors. Within the THC class of cannabinoids, delta-9 THC is the primary form found in cannabis, where delta-H THC is prepared by cyclization and has less psychotropic potency. Currently, there are 2 synthesized cannabinoids that the FDA has approved as medications in the United States, drobenol and nabilone, both of which mimic delta-9 THC. These 2 medications are the only current cannabinoids available by physician prescription. For pediatric populations, drobenol dosage for chemotherapy-induced nausea and vomiting is the same as for adults. However, drobenol used for AIDS-related anorexia, as approved in adults, is not recommended in children because of a lack of pediatric studies, with further caution recommended because of psychoactive effects. Similarly, the use of nabilone is cautioned in pediatric patients because of psychoactive effects and a lack of established safety and effectiveness. And you can look at the picture here. This is a nice example of the pathophysiology and kind of the mechanism of how it works. So first, the neurotransmitters released from the vesicles within the presynaptic neuron activates the postsynaptic neuron. Second, activation of postsynaptic neuron leads to synthesis and release of the endocannabinoid. Third, the endogenous cannabinoid diffuses back and binds to the presynaptic CB1 receptor. The CB1 receptor then activates a G protein, which leads to presynaptic events that result in inhibition of NT release. And then finally, exogenous drugs directly activate the CB1 receptors to stimulate the endogenous cannabinoid system, which enhances its function. Medical cannabis use. So, nausea and vomiting due to chemotherapy. Of 28 different studies, there was greater benefit of cannabinoids compared with the placebo, but it did not reach statistical significance. And then appetite stimulation, HIV and AIDS infection. Of 4 studies, drobenol was associated with an increase in weight gain when compared to the placebo, but this again failed to reach statistical significance. Chronic pain, when looked at in 28 studies, it suggested improvement in pain measures associated with cannabinoids, but did not reach statistical significance in individual studies. The average number of patients reported a reduction in pain by at least 30% with cannabinoids than placebo. And then spasticity due to MS or paraplegia, there were 14 studies done. The cannabinoids were associated in improvement in spasticity, but these again did not reach statistical significance. And then depression. So there were 5 studies done. 3 of these studies suggested no difference between cannabinoids and placebo in depression outcomes. Medical cannabis for pediatric use. In chemo-induced nausea and vomiting, there were 6 studies that showed that nabilone decreased nausea severity and frequency of vomiting when compared to drobenol. On average, children had an average of 6 emesis episodes compared to 17 episodes of emesis among patients given drobenol. In epilepsy of 11 studies of medical cannabinoids, the treatment of seizures in children and adolescents, they found that in a retrospective chart review of 12 children, it was found that drobenol solution given twice daily reduced spasticity and was continued for a median of 181 days with no habitation observed. In spasticity, researchers in 2 studies concluded that there was substantial evidence that oral cannabinoids benefit patient-reported spasticity symptoms. For neuropathic pain, there was 1 case study that evaluated drobenol for treatment and found that conclusions are limited. And then in PTSD, researchers in 1 case report that there was an association between cannabis use and increased PTSD symptom severity. And then finally, Tourette syndrome. In 1 case, there was a report that THC was found with a reduction in tic severity. Administration methods. So cannabinoids can be administered orally, sublingually, topically, smoked, inhaled, mixed with food, or even made into tea. Cannabis can be taken in a herbal form, extracted from a plant naturally, or manufactured synthetically. So if you want to pause this presentation, you can watch the video on how to use medical cannabis. Who can prescribe? States that allow the use of marijuana for medical purposes restrict access to marijuana unless an individual has a qualifying medical condition. States where medical marijuana is legal require patients to first obtain approval from a primary care provider, usually that is in the form of a note or an ID card. And then as marijuana is a controlled substance, physicians and nurse practitioners cannot prescribe it. They can only recommend its use to patients. Once authorized, patients can then obtain marijuana through either a dispensary or a caregiver. A dispensary is a private business that has permission to sell marijuana under various restrictions. A caregiver is an individual who is licensed to grow marijuana and provide it to authorized people. Many states restrict the number of people a caregiver can supply with marijuana. Medication and dosage. So the Dromonol comes in strengths of 2.5 milligrams, 5 milligrams, 10 milligrams, and 5 milligrams per ml. Common uses include the usual adult dose for nausea and vomiting, which was chemotherapy induced. The oral solution recommends the initial dose at 4.2 milligrams orally every 1 to 3 hours prior to chemotherapy administration, and then every 2 to 4 hours after chemotherapy for a total of 4 to 6 doses a day. You can give the oral tablets. The initial dose for that is 5 milligrams orally every 1 to 3 hours prior to chemotherapy, and then every 2 to 4 hours after chemotherapy for a total of 4 to 6 doses a day. And then the usual adult dose for anorexia include the oral solution, which is the initial dose of 2.1 milligrams orally 2 times a day, 1 hour before lunch and dinner. And then you can reduce the dose to 2.1 milligrams orally once a day, 1 hour before dinner, or at bedtime for patients unable to tolerate the 4.2 milligrams per day. And then the oral tablets, the initial dose is 2.5 milligrams orally 2 times a day, 1 hour before lunch and dinner. Reduce the dose to 2.5 milligrams orally once a day, 1 hour before dinner or at bedtime for patients unable to tolerate the 5 milligrams per day. And then the Nabilone capsules, the strength is 1 milligram. Common uses include the dose for nausea and vomiting, chemotherapy induced. The recommended dose would be 1 milligram or 2 milligrams orally 2 times a day. The initial dose, the dose should be given 1 to 3 hours before the first dose of the chemotherapeutic agent that is administered. The lower starting dose should be used to minimize side effects. The dose can be increased as necessary. Recreational versus medical cannabis. The marijuana plant is comprised of over 100 chemicals known as cannabinoids, with each of these having different effects on the body. The two main chemicals used in the medicinal application of marijuana are THC, this is the psychoactive compound in marijuana, and CBD. This substance does not produce any psychoactive effects. Recreational marijuana is pot that is used without medical justification. Recreational marijuana usually has more THC content than the medicinal variety, as this is what users use to get a high. Medical cannabis refers to the use of cannabis or cannabinoids as a medical therapy to improve symptoms and or alleviate symptoms. When people speak about medical marijuana, they're talking about using the whole unprocessed plant or the chemicals contained within it to alleviate the symptoms of a certain condition or disease. It is important to note that the FDA does not approve or recognize the plant as a medicine.
Diagnostic criteria. There is a lack of evidence for efficacy of cannabis in treating medical condition. Recommending cannabis for medical purpose is at the discretion of the provider in accordance with the current standard of practice in compliance with state laws, rules, and regulation which specify qualifying condition. The Compassionate Use Act named certain medical conditions may be helpful but not limited to cancer, anorexia, AIDS, chronic pain, spasticity, glaucoma, arthritis, and migraine. Risk management for providers. Some questions for providers when administering cannabis are: does the provider feel they have sufficient knowledge to prescribe? Does the provider feel they have proper knowledge of the different form of substance, dosage, effectiveness, identifying and managing adverse effect, the current policies on the administration of cannabis? The provider also needs to consider: is cannabis contraindicated with pre-existing medication or treatment plan? Is there any reliable mean of determining dosage and substances? Would the healthcare facility allow the patient to vaporize or smoke dry marijuana? Cannabis risk management. The guidelines for the recommendation of cannabis for medical purpose from the Medical Board of California adopted the final guidelines and factors. Physician patient relationship. The decision to use medical cannabis should be a shared decision between the patient and provider. Therefore, the physician should document an established patient physician relationship prior to authorizing or recommending cannabis in patient care. Attending physician should be the only provider recommending cannabis after conducting a medical examination of the patient before recording the use of medical cannabis for a serious medical condition. Patient evaluation. A documented medical examination and thorough history and physical must be obtained prior to making a decision on the use of cannabis. The examination should include the patient's history of present illness, social history, past medical and surgical history, alcohol and substance use history, family history, specifically looking at addiction, mental illness, documentation of therapy, and diagnosis requiring the use of cannabis recommendation. With informed and shared decision making, the decision to recommend cannabis should be a shared decision between the physician and patient. The provider should discuss risk and benefit with the patient. Moreover, patients should be informed that there's a lack of standardization of cannabis preparation and may affect others differently. Patients should be reminded that cannabis can affect the cognitive ability. Thus, the patient should not operate motor vehicle or engage in any hazardous activities while under the influence. If the patient is a minor, then the guardian should be consulted. Cannabis risk management continues. Again, this is based on the guidelines for the recommendation of cannabis for medical purpose from the Medical Board of California. They adopted the final guidelines and factors. In regard to treatment agreement, the objectives should be established with the patient early on in the treatment process. The objectives should guide choice of therapies, including pharmacologic and non-pharmacologic. The objectives should include measurable goals that will be used to evaluate the progress. The treatment plan should include an exit strategy for discontinuing cannabis if tapering or termination is deemed necessary. The physician should keep a written treatment plan that includes variability of quality and concentration of cannabis, disease or disorders, potential adverse effect, determination that the patient may benefit from cannabis, advice about other treatment options, using cannabis during pregnancy or breastfeeding, safeguards additional diagnostic evaluation, specify the duration for cannabis authorization, usually no greater than 12 months is preferable, and ongoing treatment plan. In regards to ongoing monitoring and adapting the treatment plan, the provider should regularly assess the patient response to an overall health. The assessment should include any changes in the physical and psychosocial function, treatment efficiency, goal of treatment, medical condition, and progress of goals. The patient should have follow up at least annually or more frequently as warranted by patient concerns. Modification, continuation, and termination should be based off providers' evaluation, including progress, adverse event, and a satisfactory response. Cannabis risk management continues again. This is the guidelines for the recommendation of cannabis for medical purpose from the Medical Board of California, and they adopted the final guidelines and factors. In regard to physician conflict of interest, they deem that it is unlawful for a physician who recommends cannabis for medical purpose to accept, solicit, or offer any form of remuneration from or to a facility, immediate family, or have a financial interest in that facility. Medical cannabis benefits and risks. Explored further. Please pause and play the video on this slide by opening the hyperlink and return to the next slide. Thank you. Prescribing medical cannabis. This is according to the official publication of the College of Family Physicians of Canada. General recommendation. They recommended against the use of medical cannabinoid with lack of evidence of benefit. In regards to management of pain, it is not recommended for acute pain, headache, rheumatologic pain, neuropathic pain. Cannabis may be considered for refractory neuropathic pain if a discussion has taken place, the patient has had a reasonable therapeutic trial of over 3 prescribed analgesic and has persistent pain. Cannabis can be used as adjunct to other prescribed analgesics. Nabilone and nabiximols are recommended. In regards to palliative cancer pain, not recommended as first or second line therapy. It may be considered for refractory pain in palliative if a discussion has taken place, the patient has had a reasonable therapeutic trial of over 2 prescribed analgesic, and medical cannabinoid, or the adjunct to other prescribed analgesics. Prescribing medical cannabis continues. Again, this is according to the official publication of the College of Family Physicians of Canada. In regards to management of nausea and vomiting, it is not recommended in pregnancy or cancer-induced nausea or vomiting as first and second line therapy. It may be considered if the patient have reasonable therapeutic trial of therapies and as adjunct to other prescribed therapies. Consider naloxone, but recommend against nabiximols and medical marijuana as inadequately studied. Management of spasticity recommend against use of medical cannabinoids for general spasticity. May consider nabiximols. Prescribing medical cannabis continues. So this is a nice algorithm that kind of walks you through um, the decision process if you're considering medical cannabis. The next question will be for what? So is it for neuropathic pain, palliative pain, CINV, or spasticity in MS or spinal cord injury? If the answer is no, then they recommend against the use. If the answer is yes, then the next question is, have you tried three medication for neuropathic pain, or more than two or equal to two medication for palliative pain, or if refractory to the standard therapies for CINV or spasticity in MS or spinal cord injury. And if the answer is no, then again, they recommend against the use and advise you to try those medications first. If the answer is yes, then you may consider a medical cannabinoid as adjunct therapy. And again, for neuropathic pain or palliative pain, they recommend that you try the nabilone or nabiximols Sigmund. For CINV, try the nabilone, and then for spasticity in MS and spinal cord injury, try nabiximols and nabilone. Again, they recommend against prescribing medical marijuana, particularly smoked, as first line of as first line cannabinoid owing to high risks of bias in available studies and unknown long term consequences. In all cases, potential harm and benefits should be discussed with the patient. Video for prescribing medical marijuana. Please pause and play the video on this slide and return back to the next slide. Thank you. So we have provided two case studies that we would like you guys to work through. The first one is an adult case study. The second one is a pediatric case study. We'd like you guys to use the Colorado medical marijuana qualification, which state that the patient in Colorado diagnosed with one of the following severe, debilitating, or life-threatening medical condition are afforded legal protection under the Colorado medical marijuana law. The condition are AIDS positive, cachexia, cancer, glaucoma, HIV positive, persistent muscle spasms, post-traumatic stress disorder, seizures, severe nausea, and severe pain. The Colorado Medical Marijuana Program information states that the patient must be 18 years of age or older. If the patient is a minor under age of 18, the minor and primary parents are Colorado residents, and the minor has a qualifying medical condition after seeing two submitting certification. The patient must be resident of Colorado and provide a valid proof of residency and a valid driver's license or state issued identification card. The patient must be evaluated by a certified physician. You can find the certified physician in Colorado uh, on the website. The patient must be diagnosed with a qualifying medical condition listed above. The patient must submit an application and register on Colorado Medical Marijuana Patient Registry. If the if approved, the patient will be notified within 3 to 5 days, and the medical marijuana identification card will be mailed to the address listed on the patient's application. So, keeping this Colorado medical marijuana qualification in mind for both case studies, we'll now discuss the first case study. The first case study, the adult case study, is a 63-year-old male with ongoing lower back pain who is seen in the office. The patient was diagnosed 10 years ago. He has tried more than 4 different medications with little relief. The patient rates his low back pain between 8 and 10 continuously. The patient asks about possibly using medical marijuana. Please take a minute to answer the questions. So, in answering our adult case study, some consideration: does the diagnosis fit the criteria for Colorado medical marijuana? Yes, it qualifies as severe pain. Is the patient at least 18 or older? Yes. Eligibility without age restriction. Is the patient a Colorado resident? Yes, he provided his driver's license prior to the visit. Was the patient seen by a certified physician? Yes. Is the patient eligible based off examination? Yes. So the next step then will be to have the patient submit an application for the medical marijuana registry. He will have to upload identification card, and the program will notify the patient if he's eligible. Our second case scenario is a pediatric case study that will like you guys to use the Colorado medical marijuana qualification. The scenario goes as follows. Patient is a 9-year-old male that has been having chemotherapy induced vomiting. Patient was diagnosed with neuroblastoma at age 2. Patient has tried over 3 different medications, but the symptoms still persist. Patient states it has been difficult playing with friends because he always feels sick. The patient resides in Colorado. Mom is interested in using medical marijuana. Please take a minute to answer this question and return to the next slide. So to answer this pediatric case study, the considerations are: does the diagnosis fit the criteria for Colorado medical marijuana? Yes, it qualifies due to his cancer diagnosis. Is the patient at least 18 years or older? No. So a legal guarantor must give permission. Has the patient seen 2 providers? No. This is his first time being seen. Is the patient and mom a Colorado resident? Yes, he provided his driver's license. Was patient seen by a certified physician? Yes. Is patient eligible based off examination? Yes, but the patient still must be seen by a second physician. So the next step will be to refer the patient to another medical marijuana certified physician for evaluation before proceeding. In summary, medical cannabis has many clinical implications, including the management of side effects from chronic illness, pain reduction. Medical cannabis has the potential to work effectively when other pharmacological methods have failed. Guidelines differ from state to state, and there are many legal implications to consider. Providers should be aware of both the benefit and risks of medical cannabis and remain educated in order to treat patients effectively. Thank you. References. References continues.